Everyone, today I want to talk a little bit about cervical motion. Particularly, we're going to be talking about cervical rotation and what's happening between the cervical facet joints or the zygapophyseal joints and the uncovertebral joint. I think it's probably most people aren't really aware of how that whole rotation happens, so I've created this model to try to explain it. So when we're looking at it from this perspective, you can see I defined rotation as a circular motion where when one facet goes down, the other facet goes up. So that's how we could define rotation. It's quite easy to imagine that there's a center axis of rotation here. So this is happening within the plane of the facet joint. So if I just turn this a little bit to the side, you can see how I put this circle within the plane of the facet joint. So the facet joint is right here. And that's how joints move. This C5 is going to slide over C6 within the plane of that motion. These joints do not jam against each other. They're meant to glide over each other. So what's interesting is that when we line up that circle, and I put another circle over the body of the vertebra, and you can see here that between C5 and C6, the shape of this uncovertebral joint has a arcing aspect to it. And that when we have the rotation to the left, we also have this glide of C5 over C6, essentially sort of to the right here. It's just sort of drifting off to the side like that, and the disc is allowing that motion to take place. That is how our body achieves rotation. Now also bear in mind that the rotational axis is not in line with my pen here. The rotational axis is actually 90 degrees to the plane of that circle. So the circle is here, and the rotational axis is like this. So it's literally that C5 is spinning over C6 like that. Okay? So this is a key thing to understand about rotation. So whenever the joint wants to go to the side, what's going to happen is the muscles are going to control it and turn it into a rotational motion. So we could think of this as kind of like a lateral flexion. It does look a lot like a lateral flexion, but this is kind of what we call coupled motion. It isn't just tipping to the side. A joint doesn't really just tip to the side, because if it tipped to the side, then we'd be jamming one facet straight into the other, okay? And it can't rotate the way we describe rotation. It happens somewhere in between. Sometimes we call that coupled rotation, but it's just rotation. If you look at how this joint is designed, that's how it rotates, okay? Plain and simple. Now, when the joint goes forward, so one joint goes over another, so if one goes straight forward and the other goes straight forward, we could call that flexion and extension. So flexion and extension takes on a slightly different type of a motion, and I have a little model here I can show you. So here we have the same joint, C5, C6, and when C5 glides over C6, so I turn it a little bit like this, you can see how, imagine that this one's going in the same arc of motion. When the facet joints, one is sliding over the other, they're arcing like this, but now the axis of rotation isn't here where it was before. It's actually below the joint down here. And when people study flexion and extension, all the studies are always saying, well, the rotational axis is not within the joint. They're surprised by that. But if you just look at it, it can't actually arc that quickly. So the rotational axis is kind of down below the joint. And also this varies. It depends. It depends on which muscles are contracting, because if some muscles are contracting quite close, you can actually turn this motion into a more acute motion that we would associate with flexion and extension, or you can lengthen that motion and move the axis a little bit further away and further up, and what's going to happen is you have more of a protraction and retraction. I'll show you that on a model in a second. Now, interestingly as well, is that we don't just simply have a forward motion like this. We have this forward translation. When we try to go to the side, we rotate, okay? But when we go at 45 degrees, because of the shape of the facet joints, it takes on a slightly different function. So I'm going to show you that. I have another image here. And what's happening here, as I've described again, C5 over C6. And when we go at 45 degrees, then that's actually happening more as a, sorry, it's a little bit out of focus here. So we can get some focus back. There we are. What's happening is it's going in a plane like this, and it's just translating that way. So this is a different sort of a function, and it's going within the plane of the facet joint, but it's going at an angle like that. So there's no arcing here. It's literally just one flat sheet sliding over another flat sheet. So the uncovertebral joint allows this to go in a straight line to a certain extent. But there is a very interesting straight line motion here. And this is also very important because this particular motion is resisted by the attachment points of multifidus. And multifidus is obviously very important for spinal stability. So I'm just going to show you now on a model a little bit what that looks like. And let me just put this slide on here, and I'll show you how this works in an articular model. So here, if we take C5 and C6, what we have is we can show you here rotation. So rotation happens like this. Okay, that's rotation. Just like was in the model, it was showing this type of motion. So if we start from here and we do this motion and you flip it over, you're going to see that the joint slides like this. Okay, it's pretty easy to see. Okay, I'm not sure most of us are aware of that, but that's how the joint rotates. This is joint rotation. Welcome to joint rotation. Okay, it does not happen like this. The joints don't jam. Don't try to jam the joints like that. Don't try to laterally flex the joints like this. They don't do that either. They rotate like this. Okay, so if you want to get rotation, you have to think about this what we call coupled rotation. It isn't really. All it is just rotation with an axis, which is 90 degrees to that plane of the facet. Okay, it's plain and simple. It's not coupling anything. It's just simply the way the joint is designed to move. It just does that. Okay, that's how it moves. It's very, very simple. When we have translation, if both these joints are going in the same direction, they're sliding over each other like this, okay, then what we often have is what we could call flexion and extension. We have this motion like this, flexion, extension, or we could have protraction and retraction. So it just depends on whether it's going kind of more straight up like that with a kind of a bigger arc, okay, or a more acute arc with flexion and extension. So it's pretty much flexion, extension, protraction, retraction are cousins of each other. It just depends on exactly which muscles are contracting. So what's interesting is that has an axis of rotation, which is abextra to the joint, which is kind of more forward and below the joint, and that's how that arc is taking place. Okay, so that's important to understand. But also, we have a motion, physiologically we have a motion that goes at an angle which is about 45 degrees off to the side like this, and what that's doing is that's going pretty much in a straight line. It just drifts straight like this. Okay, the joint is designed to move that way. Okay, so it just goes like that. It doesn't arc in one direction or the other direction. If you're rotating, it rotates. If you're going forward and backward, it arches the other way, but when you're going 45 degrees, it's pretty much a straight shot. So this is a kind of interesting motion, but it's also a motion that's kept in check by the multifidus. So whenever we take a step, if you take a step and you take a step onto your left foot, your head is going to continue forward and your whole spine is going to get thrown in this direction. So it's quite typical to have these kind of cross forces that are kind of thrusting your joint in one direction, and the thing that's resisting that force are these intrinsic spinal muscles. So multifidus is a really, really key one that's coming down through here to try to resist that motion or keep it in check. So in other words, it's trying to make sure that the joint can move that way, but it doesn't move too far. So our body is eccentrically contracting multifidus to slow that motion down. If we have a very, very fast traumatic motion, in other words, like a whiplash, that's going to reset the gain. In other words, it's going to stretch that muscle so fast that it has to facilitate a protective mechanism to switch that muscle off or reset the gain of the muscle, which really what that means is it's making that muscle less reactive. It's reset the gain. So in other words, the relationship with its understanding of what length it should be and how reactive the muscle should be, it actually resets it to a lesser state of reactivity. So it actually makes it harder for that muscle to contract. We could say it's weak, we could say it's longer, but I like to say it's less reactive because the brain is still telling that muscle to contract, but because it's been reset, it becomes less reactive. Now what's interesting is that the muscles above and below, the multifidi, are all controlled in a homologous chain. So in other words, your body, if it senses a force throwing your head this way, it's actually going to switch all these muscles on at once. A whole group of muscles get switched on at once. We don't really have individual control of each multifidus, and certainly not under voluntary control. So the part of our brain that's reflexively controlling multifidus is actually controlling all of them at once. So when we have a trauma, what it's actually doing is it's decalibrating that muscle's reactivity with the reactivity of the other muscles. So the other muscles might give a certain amount of, if the brain says, give me 5 kilos of tension in each of the muscles, then what will happen is all of them will do that except the one that's been traumatized. It will contract less and give less force. So then that what we'll see clinically is that that joint seems to be unstable. So body doesn't like it being unstable. So what will end up happening is your body will start contracting extrinsic muscles to try to protect that joint from going too far that way. But every time you're sort of bending that way, you're feeling the resistance of the extrinsic muscles, but you're also feeling that joint isn't moving very well. Also, when these intrinsic muscles get inhibited, if they can't contract effectively, then they can't inhibit their antagonists, which would be anterior lateral on the other side. So what would happen is the anterior lateral joints muscles on the other side would be tight because they're not being inhibited anymore by this one contracting. So these get tight, and it further just cements that subluxation. So the joint literally just gets stuck like that. And the way that it gets stuck very often, again, multifidus is drawing the joint back this way. So if multifidus is weak, the joint will go forward and to the left, okay? And it's that translational kind of 45 degrees or somewhere in that vector where it gets stuck. So most of our, or I shouldn't say most, but certainly a lot of our subluxations are going to be like this. So I promise you, if you start palpating, putting the head in this position, and you start to palpate and you feel where there's resistance of that joint to come back to neutral, as you press here or here on C5 and C6, so you're pressing on it like this, you're going to see that there's a resistance of this joint to come back to neutral because there's anterior lateral tension on the other side. So what we're doing with adjusting neutral is actually putting the joint in that position and driving it back towards neutral, okay? And by doing so, we're not doing any twists, we're not doing any loading of any other muscles, but we are very, very precisely loading the muscles which are resisting the joint coming back to neutral, and our very fast stretch is again going to reset the gain of the muscle, but the muscle specifically that's inhibiting that multifidus. So we can get that one to switch off. Multifidus has a much better chance of contracting, okay? And we'll see greater stability immediately after the adjustment. So one of the keys is we're doing this within the normal motion of the joint. We're trying to help facilitate that biomechanics by resetting the gain of the muscles that are inhibiting it. And also, when we get this muscle to switch back on, the extrinsics that we're trying to compensate, in other words, your levator scapulae or your traps, whatever muscles we're contracting here, trying to keep your head from going forward and to the left, they don't need to be tight anymore, so they'll literally just melt away. So this is really, really fun stuff with adjusting to neutral, is we're just managed to fix a lot of other issues around the joint, and also the biomechanics are going to be massively improved as well. You can imagine if these anterior lateral muscles are tight, what that does is it changes the axis of rotation of the joint. So instead of the joint rotating here, it's going to shift the axis of rotation more towards where the tension is. So you have more motion on this side, but then when you try to rotate the other way, it just simply can't move. And we could often mistake that as having a lack of right rotation. So if you see this scenario, what most people will see is they'll try to take the joint off this way, and they'll say, oh my gosh, you're super, super resisted here. I'm going to just whack you all the way to the left and stretch all of your joints in rotation off to the left. And what are you doing? You very well might be stretching all of these multifidi off to the left and actually resetting the gain of the multifidus on the other side. So you might be even creating potentially a decreased reactivity of all of these multifidi, and maybe perhaps even a weakening of the neck. If we say, well, wait a minute, when we try to move your head this way as well, we're finding all this tension of the extrinsic muscles. So maybe we'll do some therapy to try to release the tension of that. Well, what are you going to do? You're going to end up leaving the joint in a type of motion where it's now unstable. Okay, so the muscles that were actually compensating for the lack of stability, you've taken all the tension away. So now that there's no compensation, and then you're just left with the joint which is stuck this way and unable to stabilize. So they'll feel more mobile, perhaps, but they're actually still very unstable. So that's why the next day or the day after, that tension comes back because your body put it there because it was fulfilling a purpose. So we have to be very, very careful about how we're treating these joints. We certainly don't want to take this joint further into that direction. Can you imagine if we feel the tension of the extrinsics on this side and we say, well, actually, gosh, your traps are so tight on that side, I'm just going to take you into lateral flexion on this side. Or we're just going to give a big stretch in this joint and try to open this up. Well, what are you going to do? Yeah, you're just going to weaken all of these multifidi on this side. So that might not be such a great thing either. So I think we really need to be careful and try to understand very carefully exactly how the joint is designed to move, how it should move, exactly what's happening in the joint, and to try to find a way to palpate and to understand what failures of function we have but at least if we try to align our understanding or the goals of our assessment towards how can the joint get back to its stable position. What is keeping the joint from getting back to a stable position? Is there anything I can do to bring that joint back towards a stable position? Is there anything I can do to create a balance of these intrinsic muscles? Is there any way I can be more precise with the types of therapies that I'm applying to the joint? Is there anything I can do with my understanding of how these joints move so that I can, when I'm palpating, I actually know what it is that I'm trying to feel here and what types of motions I'm trying to instill? So these are sort of questions I hope to inspire in you guys and hopefully get a little conversation going. But certainly what I can say is that for myself and the other practitioner of adjusting to neutral, this is a very, very fast way to resolve these types of issues. So not only can you create a greater motion of the joint, but you can improve the biomechanics because now you have greater stability of the joint. The intrinsics can guide the motion of the joint better. You're going to be able to, if the joint is stable, there's no need for these extrinsic tensions to be there anymore. And the body will literally just let those go without even having to do anything. You don't even have to blow on it, it just lets go. So it's really fun stuff. It is actually possible to resolve these things very quickly. And really all of these answers have come out of the question of, gee, if there's one force that could drive the joint in a direction that could create this trauma and resetting of the gain, is there some way that we could actually understand that so that we could create a reversal of that function to reset it back in the other direction? That's precisely what we're trying to do with adjusting to neutral. We're trying to understand what happens in a neck trauma, okay? And we're trying to find a way to resolve that motion or that imbalance with literally an equal and opposite force to the trauma, but it has to be applied very, very precisely. So anyway, I just want to thank you all for sticking through it if you have, and if you have any questions, please let me know, and I'll be glad to go into more detail or less, depending on what you like. Just please keep in touch, let me know what you want, and thanks for watching. I'll see you next time.